Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes.
Today, we're joined by Dr. Satya Sarma, a physician leader and healthcare executive with deep experience across public health, Medicaid, and payer systems. She is currently the medical director at Arizona Best Care Network and is working to enhance access to care through community health workers at Asian Pacific Community in Action, where she serves as interim president of the board. Throughout her career, she's focused on improving outcomes while lowering costs, and more importantly, figuring out how to actually make that happen in the real world setting. Dr. Sarma, welcome to the show.
Thank you for having me.
Absolutely. Before we dive in, can you tell us a bit more about your journey and why you feel so passionate about the work you're doing?
Well, I came out to Arizona pretty much straight out of residency and was able to fulfill my lifelong dream of, being a doctor in a community. I described that phase as being a country doctor. I was out here in the West Valley at a time when, we didn't have a lot of healthcare specialists, a lot of density. Was in practice for 16 years. I set up my own practice, learned the business side of it as well. And as managed care started entering the market, really started understanding its promise as well as its potential challenges, particularly for physicians working in the community. I think what has always driven my interest are some of those early relationships I formed with my patients. At one point, I'm very proud to say I had 4 generations of one family in my practice. That's quite an achievement as an internist. I didn't do pediatrics, so that was quite something. And to learn their stories, their life stories, and to be able to be present at a time in their lives when it mattered. I realize now that where medicine's gone, that was a very precious experience. And I have so many stories from that time. That sparked my interest in this idea of how do we make the system better? Because as a physician, I touched individual lives, but oftentimes I couldn't do anything about the system the patients were in. I had a patient who missed her Medicare enrollment when she turned 65. She went a month too late. And for a year, we worked with her having no insurance right in the middle of a cancer diagnosis. And it meant we worked with her. I was in practice, so I was able to give her very affordable fees rather than have her be in a position where she was afraid to seek care. But navigating the specialists, et cetera, navigating her continued chemo and all the imaging she had, I was able to be a bit of a support, but I really couldn't do anything about that. And that's what got me started on my journey to really work in the managed care side of things and got me interested in value-based care.
Thank you for that. What I find extremely interesting is that you sit at this intersection of policy, public health, operations, real world implementation, and a lot of us only see through one of those lenses. And the fact that you can kind of see all of those parts, that 360-degree view of healthcare, if you will. I know that our listeners are going to get a lot out of this episode. I'm super excited to have this discussion with you. So in this episode, we're really focusing on value-based care theory and how we translate that into real-world execution. So my first question for you, for our listeners, can you define the model of care in a way that makes it meaningful for our listeners?
Well, first, when we talk about value-based care, I think one of the things that's happened with this term is it's really lost its core meaning in usage in the industry. When we talk about value-based care, who are we delivering value to? And that's what we need to anchor on. We're delivering value to the patient. It's the patient who wants and needs us to make sure that they have optimal outcomes without, making their costs completely unaffordable. Take that one patient and now, understand that the system is, millions and millions of patients, right? Or at least the thousands that you're probably seeing as an internist or family doctor. That's what we're trying to achieve with value-based care. So to me, value-based care is always something that requires us to have the rubber hit the road. It's not just a term, it's not just for policies. At the end of the day, it translates into every interaction that you as a physician or provider, as the term is used now, has with a patient. That's it. And what is the model of care? The model of care, essentially, your model of care, if I were to explain it as simply as possible, a model of care is your vision of how that interaction should be structured. If I were to simplify it, that's what it is. It's like your value statement, your vision statement about how patients walking in through the door are going to be treated. Not from a customer service perspective, which hopefully you have, not from a business perspective, but purely from a clinical perspective. How are you going to approach them? How are you going to engage them? What are you going to prioritize as you interact with them and meet their clinical needs?
So it seems like we kind of have these two opposing forces, right? We have fee for service. Let's see more patients. Let's provide more services. Let's have more visits. That all equals more revenue, right? And then we have this kind of abstract idea of value-based care that's like, hey, we're focusing on outcomes, prevention, decreasing total costs of care. Can you paint us a picture of what a clinic might look like when they're operationalizing this idea of value-based care? What does that look like?
Great question, because you're absolutely right? The way our system has been set up, the payment is for a service, for a unit of service. And what has happened over the years is that volume rules. Let's just take the biggest payer in our country, right? Which I believe is Medicare. Medicare sets a payment for a particular service. It doesn't take the doctor that's doing a really great job and pay them more. It pays the same for each unit of service, right? So one visit is one visit in your geographic area. I'm oversimplifying, but basically that's what it boils down to. What that means is that the doctor who sees 100 patients in a day gets a higher revenue than the doctor who sees 50, who gets more than the doctor who sees 20, or the doctor who sees 10. But hang on a second. If you walk into the doctor and you have a number of chronic problems and you have a medication list a mile long, does being one of those 50 help you? I'm guessing not, right? One of the highest compliments I think a patient can give a doctor is they gave me the time I needed. And so in value-based care, the idea is that the payment structure rewards outcomes. It rewards value, which is better outcomes for the same or a lower price. And there's a thesis here, right? Ordinarily when we go to the store, we assume that if something costs more, it's better. And while that's true to a certain extent anywhere, in healthcare it can be very much the opposite. There is a point at which having to go and get more testing that doesn't drive your care any better, that doesn't deliver better outcomes, is not a benefit to you as a patient. It's not value. It's just money out the door, right? It's something you're paying for or the system is paying for, but it's not necessarily making you feel better. If you're receiving care that's not part of your conception, your plan for your life, that's not value to you, right? So what the model of care basically is your statement of how you're going to meet patients' needs And one of the core aspects of doing well, succeeding in a value-based model is that you have to take that volume equals more mentality out of your head as a clinician. And you have to say, what I'm going to do is I'm going to give the patient what they need. If the patient in front of me has multiple chronic problems and really needs my attention to them, that patient needs a different level of care than, say, the young mom who brought in, her child for an antibiotic or a note from school. It's really about structuring your entire approach differently based on what the patient needs. It also incorporates the patients. So that's another, very, I think, something we miss in medicine, particularly when volume rules. What are the patient's goals for their health? What are the patient's goals for their lives? The treatment plan fits in. People walk into the doctor's office looking for help with their health, but that's just a tiny piece of their lives, right?
Mm-hmm.
So we really want the patient's engagement into the plan. The more complex the patient is, the more their goals and their understanding of their healthcare and their goals for life matter.
So we have these two competing forces, the fee for service, the value-based care idea. I need to make money for my practice, so I have to see patients so that I get paid. But value-based care, like, you don't see those rewards till later, right? The value, the return on investment. So is this why it's so hard for health centers to implement, or are there other factors as well that make it difficult?
Well, sure, there are other factors, but I think this is a central one from a business perspective, because you do still need your practice or your clinic to be sustainable, right? To
Mm-hmm.
be here the next day. These two payment methods often clash. Now, CMS has gone a long way, CMS and Medicaid have gone a long way in creating systems that will promote payment for value. In other words, let's pay doctors who are doing a good job, who are delivering value, who are delivering better outcomes at the same or lower cost. Let's enhance their payment. So you have models like the one AC Best Care is in for Medicare, where payment is not made on a fee-for-service basis. I mean, there is technically a fee-for-service payment that comes immediately. But overall, what happens is that it's a shared savings model. So Medicare shared savings says, if you want to sign up for this program, what we're really going to grade you on, what we're really going to reward is how you manage outcomes relative to cost. How much value you deliver is what will help you practice succeed. So those payment models help clinicians and clinics participate in a different framework than that value-based, more is better all the time. Let's not worry about how the patient does. That's not the model that they reward. They reward the model I think we know is better and what I think most clinicians want, which is to give the patients the care they need for better outcomes in a way that engages them and that meets their long-term needs and goals without breaking the bank. The hard part, though, is that I think clinics are torn between these two models. If you were going for volume, there's a certain set of things you would do. When you're working towards value-based care, they're almost the exact opposite.
Mm-hmm.
Let's just start with, so I think that all the majority of the problems we see in succeeding in value-based care start with the fact that we've set up a system that's really oriented towards volume, right down to how something as elementary as how a physician's schedule is set up. So for instance, when I was in practice, we gave out 20-minute appointments to start with for a follow-up. So every follow-up was a 20-minute visit. I can tell you that there were patients I'd see where just going through their medications, making sure you had the medications fully written down at the dosage they were taking at now, took almost the entire 20 minutes, page and a half of medicines. So towards the end of my practice, I actually started a chronic care model, which was, this is way back, 2008 or something like that. And what I did was I kept the patients with multiple chronic conditions in a separate registry. And for those patients, I actually changed my model completely. I had 1 hour initial visits for them.
Mm.
I offered them home visits. I had a model that incorporated comprehensive care needs. So not just their conditions, but their nutrition, their mobility, their medications, their ability to afford things. All of that got incorporated in the model. And I was able at the time, because CMS was actually publishing things like readmission rates for certain conditions, I was able to show a vast improvement in a matter of months by simply changing the approach to the patient. So what value-based care tries to do, what these value-based payment models are supposed to try to do, is reward practices that make those changes. So they don't feel like this means I'm going to actually suffer economically because I'm not doing the 50 visits, or 50 is an exaggeration, but let's say 20, 40 visits that fee-for-service medicine requires for me to be able to make my rent and my utilities and my salaries and so forth.
As patients, we sense the urgency of our clinician when they have all of these visits, or because there's the 20 minutes it takes to reconcile a list of medications, and then there's the other things that you need to address, then it's like the domino effect, and now the last patient is waiting for an hour to be seen because of that. I understand the sustainability piece, but I love it that you're so patient-centered in the way that you think and the way that you approach the situations.
Well, in my experience, that's why clinicians go into the field, whether they're doctors or nurses. Young people going into these fields go into them because they do want that connection, because they have this desire to serve. Primarily, that's what I see.
I agree.
I think this touches on something, right? Like, I think, one of the things I've been thinking about of late is, what exactly is medicine, right? Medicine has this very long storied history in human civilization. For example, when Margaret Leakey was asked, the famous archaeologist who discovered, I think it was Lucy, or you can't remember, but she discovered one of these ancient hominids, right? And so she was asked once, when do you see in the fossil record civilization emerge? And she answered something to the effect of, well, when you see a broken bone that's been set and healed. Because what does that mean? That means society was at a stage where they were willing to say, this is one of our own, leave them behind. We're going to heal their illness, and they're going to come with us. Medicine and healthcare is this very core connection in society that binds it together, really.
Yeah.
The idea that the payment system erodes that is actually a really important facet that I feel we're missing. What are we doing to our society when we set up systems and policies in such a way that the patient doesn't feel they can get the help they need, or they feel rushed, or they feel like I'm not going to get the attention I need for the problems I have? I know that's a sort of like a meta point, but the older I get and the longer I've seen this, I feel like these are very core issues that we should be really careful about how we approach at the policy level. And I understand that this is something very foundational to the very concept of society, which we all depend on to be able to survive and to thrive.
Absolutely. It makes me feel sad that we're operationalizing healthcare and medicine to be just like any other business. Manufacturing could be like that.
You hit the nail on the head, right? Like I really think we need to think about healthcare differently. And you could say that's because this is the field that I chose. But I think it becomes more obvious to you when you have family who needs health,
Mm-hmm.
care, or when you need healthcare or your
Mm-hmm.
child needs healthcare. Then it becomes poignant, right? These
Yeah.
stories that when it goes wrong, the stories that you say really impact you in a more deep way
Mm-hmm.
and at the core of your being, more than product that wasn't ideal.
Yeah.
Right?
Yeah.
So this is there's a little more at stake, obviously.
I think we definitely need to reintroduce the human component.
I think the most important thing is, in the heat of the day, and with these pressures that clinicians face in living in this volume dominated healthcare system, I think just articulating that model of care is actually the key thing. So, to your point, defining what you want to achieve is very important. But
Mm-hmm.
in general, what we're looking for to succeed in value based care is um, some ability to stratify and anticipate which patients are at the highest risk for poor outcomes, and then incorporate a holistic, a comprehensive model of care that addresses not just what medications they need to be on or what testing they need, but also things like their social needs,
Mm-hmm.
their behavioral needs. Are they lonely? I mean, one of the most common coexisting conditions with heart disease, for instance, is depression. So you could get someone's heart stable, maybe their angina is stable, but if they're depressed, you haven't really achieved their health yet, right? Like you still need to address that component. So having a comprehensive model of care that really depends on the patient's input. So that's
Yes.
the other component, right? Like you want a patient, you want a plan of care that is brought in a patient-driven manner. That is that the individual, it's an individualized plan that incorporates the individual's care needs and goals. And then their literacy, their understanding is very important. Those are the important sort of like, things to think about in a model of care. It can be very helpful to make sure that you have a team approach that includes, case management as we know it, right? Someone who is helping address, well, I wrote their prescription, but we're sure they got their
Mm-hmm.
medicine,
Mm-hmm.
right? That's the kind of thing a case manager can just make sure that their health plan's going to cover this medicine, or maybe we need to switch it to something else, or do they have social needs like transportation needs for their follow-up, or is there a benefit that they should be on that they're not signed up for yet that could help
Mm-hmm.
them?
Mm-hmm.
In our next episode, Dr. Sarma takes us beyond the theory of value-based care and into the real-world challenges of implementation, sharing practical strategies for identifying high-risk patients, improving outcomes, and building systems that support lasting change. Be sure to subscribe, and thanks for being here in the exam room.